Hi, good evening, everyone. I would like to welcome you all to capitalizing on personalized care in IDH mutant gliomas, which is a session which is being done under the auspices of Peerview in collaboration with ABTA with an educational grant from Servier. My name is Dr. Manmeet Ahluwalia. I'm a medical oncologist by training, and it is my distinct pleasure and honor to be doing this session with Dr. Patrick Wen, who's the Director of Neuro-Oncology at the Dana-Farber Cancer Institute, and a very dear friend and mentor. Thanks to Peerview and the ABTA for providing this session, and Servier Pharmaceuticals for providing the educational grant for this symposium. If you have not already done this, please complete the peer event survey. Actually, there's a QR code where you're sitting. It'll be good to be involved. Please also look out for additional polling during the presentation. We would like this to be an interactive session. Please submit your questions and we will answer them during the Q&A session in the end. In the in-room learners, please use your personal device to scan the QR code on the following slides to respond to polls, and feel free to ask any faculty questions. We wanted to give everyone an incentive, so those people who are participating in person and are in room, please ask questions, because the best 3 questions actually get a $50 Amazon gift card, which is provided by Purview, and Jessica will adjudicate who are those 3 winners, and so you need to stay till the end, and we'll announce the winners before this program finishes. And also, if you need the slide set, you could actually visit peerview.com/2024glioma, and you'll be able to download the slides and the practice aids after the event tonight. What are our goals for tonight? We want to enhance your understanding of the latest evidence and practice guidelines supporting the use of molecular testing and targeted therapies in patients with IDH mutant gliomas. We want to equip you with the strategies to identify eligible patients with gliomas who may benefit from IDH inhibitors, including clinical trials updates, biomarker findings, recent regulatory approvals, and clinical practice guidelines. It will provide guidance on how to address the nuances of treatment with IDH-targeted therapies, including adherence, adverse event management, appropriate dosing modifications, and patient counseling. We, as always, are extremely grateful to our partner, the American Brain Tumor Association, which is an excellent resource for patients and care partners for glioblastoma. As you know, ABTA's mission is to advance the understanding and the treatment of brain tumors with goals of improving, extending, and ultimately saving the lives of those impacted by brain tumor diagnosis. Thanks again, ABTA. Obviously, it is all about the patients. That's what our mission and our North Star is, to serve our patients. So we are very thankful to ABT again, and Linton Daniel, who's a patient with grade 2 oligodendroglioma, for sharing his journey. He spoke to Ambreen, our project manager at ABTA, about his disease journey.
Hello, my name is Ambreen Maan, Program Manager here at the American Brain Tumor Association, and we are so delighted to work with Peerview on this symposium and program. I have with me today Linton, and Linton, I'll have you introduce yourself to our audience.
Thank you, Ambreen, and thank you very much, ABTA, for the opportunity for me to speak about my experience as a brain tumor patient. I have an oligodendroglioma stage 2. I was first diagnosed over 13 years ago at UCSF. We knew from the very beginning, from my initial diagnosis, that it would have to be only a subtotal resection. In other words, he could not get more than 2/3 of the tumor out of my brain. So from the very beginning, I knew I was probably not going to have standard of care.
So thank you for sharing the video. Now we're going to talk about the molecular pathways. So we all know that genetic drivers drive the outcomes in cancer. And in brain tumors, in the last several years, in fact, the 2 iterations of the WHO 2016 and more recently 2021 has really taken into account IDH mutation, which has really become the cornerstone on how we are now classifying gliomas. A big change in 2021 was that the patients who have IDH mutant gliomas cannot have glioblastoma, because previously we used to have grade 4 glioblastomas who could be IDH mutant. So here you can see distinctly we divide our IDH mutant gliomas into oligodendrogliomas, where you can have grade 2 or grade 3. There they have a concomitant 1p19q deletion. Often there are additional characteristics seen in these patients, which include third promoter mutation, CIC mutation, FUBP1 alteration, as well as Notch1 overexpression. On the other hand, astrocytomas, who tend to be IDH mutant now, can be grades 2, 3, but also 4. And these are often characterized with ATRX loss, P53 alteration, CDKN2A or CDKN2B homozygous deletion. And the tumors which are IDH wild type tend to be classified, especially with grade 2, tend to be classified as glioblastoma. Additionally, these tumors tend to have third promoter mutations, chromosome 7 and 10 alterations, along with EGFR amplifications. And previously, these tumors could be grade 2 and 3, but now they tend to be classified as glioblastoma. What is the epidemiology of IDH mutant gliomas? 12% of all glioma diagnoses in 2018 were IDH mutant. And as I discussed, they can go from grades 2, 3, 4. Oligos tend to be grade 2 and 3, and astros can be grade 2 to 4. The lower grade tumors tend to have more IDH mutations compared to the higher grade tumors. And also the highest incidence is seen in people in their 30s and 40s, with the median ages of 35 to 45, that decade being the highest incidence. And it tends to be more in men compared to women, and the ratio is 1.3, higher incidence in men compared to women. And the bar graphs again showcase the same thing: greater number of IDH alterations seen in lower grade tumors compared to higher grade tumors. So what are the challenges in these IDH mutation gliomas? Obviously, there is SEER data, as you know, houses the outcomes in real-world evidence. And what it has showcased is that the OS of these patients had not changed significantly in decades, but we used to use radiation and chemotherapy. And you'll see exciting data that Dr. Patrick Wen will present in some of the ongoing clinical trials I'll present, will showcase how targeted therapy is really truly transforming the outcomes for these patients. But the critical component there is molecular testing, because as I said, it is essential to get a profiling of patients with brain tumors, because what we have found out is that not enough or not everyone that we see with brain tumors gets profiled. And as I had told you, IDH alterations are an essential component of really performing the diagnosis of patients with gliomas. And this number has been even around 68.5% of patients were getting profiled. So we can definitely do better. There are some persistent gaps in taking care of these patients, and it's very essential for us, those of us who take care of brain tumor patients, know that we are not only taking care of patients with tumors, but it also has an impact on their neurological function and quality of life. Patients who have a larger tumor typically have more burden of disease. They can often have shorter survival. Their performance status can be impacted, and that makes determination or impact on how aggressively we can treat them. We also do know that IDH mutant tumor patients can have greater epilepsy burden. There's some work from Craig Herbensky showcasing that they can even have greater incidence of thromboembolic phenomena. Also, the socioeconomic status of our patients can impact what kind of physicians and centers they can go to and what kind of treatments that they can get. So there are gaps in quality of life, and there is a very nice poster. Actually, I would encourage all of you to go and see it in Hall B3 tomorrow between 7:30 to 9:30. And it is looking at understanding the burden of mutated IDH1 and 2 gliomas and the complexities of navigating the patient pathway, which is insights from patients and their caregivers. And all of us who have taken care of brain tumor patients know that we become very close to our patients and their caregivers. And again, a shout out to ABTA, which has been a remarkable partner and a resource for providing education for our patients. What has been some of the cornerstones of treatments of patients with lower-grade glioma? This was a landmark trial done under the auspices of RTOG, now the NRG. Jan Buckner, led this study, which was published in NEGM several years back, and basically showcased that the combination of radiation and chemotherapy was superior than radiation, because traditionally we used to treat these patients with radiation alone. And you can clearly see those patients who got combinatorial treatment with radiation and chemotherapy almost had twice as good outcome, with a median survival of over 13 years compared to 8 years with radiation alone. And on the right side of the curve, you can see definitely better outcomes in patients with IDH alterations when they got the combination compared to radiation alone. There was then work done by Dr. Bell and Arnab Chakravarti, who actually went back and profiled all these patients who were treated on the RTOG 9802 study, and they basically showcased that the progression-free survival and overall survival in these patients with low-grade gliomas was primarily driven by IDH mutant patients. Also, they were the majority, and you can clearly see the outcomes of those patients who have IDH mutations along with 1p19q deletions actually do the best, followed by those who have IDH mutations. And those patients who had IDH wild type actually did not get any benefit with the combination of radiation and chemo. There was also an effort going on at the same time to see if we could even delay radiation and treat these patients with just chemotherapy. And as you know, temozolomide has been really the foundational chemotherapy we've treated our patients with in the last 2 decades. And this was a study led by Daphne Haskogan, Susan Chang, and Dr. Wall at UCSF, and showcased that when we gave patients just temozolomide, your overall survival was just around 10 years. So definitely the combination of radiation and chemotherapy, although not directly comparable, was superior at 13 plus years. We do know that there is molecular results of these alterations, and IDH mutations lead to overexpression or excess to hydroxyglutarate, which then causes genetics and epigenetic dysregulation, leading to oncogenesis. So 2-HG is actually an oncometabolite. These are molecular hallmarks of IDH mutant gliomas, and as I had told you before, those patients who have IDH astrocytomas tend to also have ATRX alterations, P53 alterations, CDKN2AB alterations. Those who tend to have oligodendrogliomas, they have a co-deletion of 1p19q on top of IDH alteration. These also tend to have more of TERT alterations, CIC, FUBP1 alterations, as well as Notch1 overexpression. The good news is that not only can you find IDH alterations in tissue, you can actually even find them in plasma. And as you know, there's a lot of interest in liquid biopsies these days. And there was this study which showcased a concordance between tissue and plasma when they looked at 67 samples. And what both of them showed that patients who have IDH mutations have a much better outcomes compared to those who do not. So based on this, I will open this up to discussion with Patrick. Patrick, you saw some of the data that despite ideally we would think all of these patients should be profiled, that only around 70% of these patients are being profiled. So if someone comes and sees you who has a low-grade glioma, say I have a 37-year-old patient who presents with residual grade 2 glioma, which is confirmed on MRI, what are you doing in terms of biomarker testing and profiling for these patients?
Yeah, the biomarker testing is crucial. I think the first step is the surgeon has to get enough tissue, and so just a simple biopsy, enough for histology is not adequate. The biopsy, hopefully you resect the tumor, but if you have to biopsy, you have to get enough tissue. But we also know that histologic grade 2 tumors are not all grade 2 tumors. If they have CDKN2A loss, then if it's an oligodendroglioma, it becomes grade 3, and if it's an astrocytoma, it becomes grade 4. So the molecular testing matters. And then there's also a subset of grade 2 tumors and grade 3 tumors that look like low-grade tumors histologically that are IDH wild type and have the molecular alteration suggestive of glioblastoma, TERT promoter mutation, EGFR amplification, and loss of 10 and gain of chromosome 7. So these are molecular glioblastomas. So just looking at the tumor and calling it grade 2 is really not adequate in this day and age, and molecular testing is really important.
Sure, thank you so much. And I would highly recommend having, there are multiple panels which are available through Foundation Medicine, Caris life sciences testing. Tempus, you can pick the one you want, but I would highly encourage sending this tissue out for molecular profiling in these patients. So before we move forward, please feel free to look at this QR code and take a moment to answer the follow-up polling questions about the mechanistic rationale for targeting IDH alterations. So Linton now discusses his therapeutic journey that ultimately led to an enrollment on a clinical trial for a novel IDH therapy.
I hear you talking, about the IDH mutant, IDH inhibitor treatments as well. Can you talk to us a little bit about molecular profiling and, at what point was that a part of your diagnostics or care? Was that something that was offered to you right from the get-go at your initial diagnosis? Did that come later on?
It came after my first surgery, because that's the only time that it can come. And so I was diagnosed way back when, of course, and then several years later I was operated on, which of course was January 6, 2016. So my new neuro-oncologist, the really wonderful Jenny Taylor here at UCSF, she said, we've done the UCSF 300 screen looking for mutations, and you have a mutation. And so we're definitely going to put radiation in our back pocket. And after you've recovered from your surgery, you'll start taking everolimus, which was in the clinical treatment research phase at the time. It was terrible, absolutely terrible. They don't use it anymore. I was lucky I even made it through 2 years of it. But it was either that or Temodar, and I certainly didn't want them to take Temodar. So yes, that was the first time that I went through a molecular profile. The second time I went through a molecular profile was immediately after my second surgery, which is in October of 2018. And that confirmed the same thing as before, IDH mutant and various other things. And so that formed the basis, of course, for my inclusion, partly of the basis for my inclusion in the, or what at that point was called AG881, investigational drug trial. This is a whole new territory, and it's a different kind of a thing than showing up for the Temodar infusion or whatever it may be. So it's history in the making, of course, and we have lived with this. We're living examples of all this process, and I think we're all very proud to be part of that. I mean, the people I've spoken to are thrilled to have been part of this.
So I'm going to talk about the development of IDH inhibitors, and thank you, Mamit, for having me, and thank you, PeerView and the American Brain Tumor Association. So standard therapy is a maximum safe surgical resection. And for low-grade gliomas, if you achieve a gross total resection and you're under the age of 40, up until recently, you're considered low risk and you can be observed. But if you're above the age of 40 and you have residual disease, you're considered at high risk. And the recommendation is to have radiation and chemotherapy, usually PCV for oligodendrogliomas and temozolomide for astrocytomas. And for grade 3 tumors, regardless of the extent of resection, the recommendation is radiation and chemotherapy. These treatments are helpful, but as patients survive longer, there's also the issue of long-term neurocognitive issues. Over time, the treatment recommendations for these tumors has changed. I won't go into details, but now in the NCCN guidelines, IDH inhibitors are included in different aspects of the algorithms. The NCCN just had a meeting at the end of October, so there'll be updates to this guideline that will come out probably early next year, that will have changes. But IDH inhibitors are available both for newly diagnosed and recurrent tumors as an option. So Mamit talked about these IDH mutations driving tumor growth, and it's an early transformational mutation. In early studies with inhibitors, there was slight slowing of tumor growth, but there was a lot of skepticism initially, and the thought that maybe when you have IDH mutations, it's not possible to reverse that process. And these very modest results in laboratory studies also provided some support that maybe IDH inhibitors might not work. The first-in-class IDH inhibitor was ivosidenib. This is an IDH1 inhibitor that was known not to get into the brain very well. And in that study, low-grade tumors that were non-enhancing had prolonged stable disease. But you can see lower down that there are also some grade 3 tumors, predominantly non-enhancing grade 3 tumors that also had benefit. One of the problems is when you have a slow-growing tumor and you have prolonged progression-free survival, you're not really sure your drug is doing anything. It could just take you a year or so to figure out that your tumor is growing. So very careful imaging studies were done and showed that the tumors were slowly growing on study, and after treatment with drug, there was leveling off of the growth of these tumors. Vorasidenib was subsequently developed. This was developed as a brain-penetrant IDH1 and 2 inhibitor, and it again showed a number of patients with prolonged stable disease. Then to understand the effects of these drugs on the tumor in more detail, a surgical window of opportunity study was done, and this really is probably the best example of this type of study and should really be done for most of the drugs we're looking at for our patients. So in this study, patients with grade 2 recurrent IDH-mutated gliomas who needed surgery were treated either with nothing, with different doses of vorasidenib, or different doses of ivosidenib for a month. And then patients after that month went for surgery, and the tissue was evaluated both for drug concentration and also inhibition of the IDH pathway as determined by lowering of the 2-hydroxyglutarate levels. In that study, the response rates were somewhat higher than in the phase 1 study, and there were many patients with prolonged stable disease. When you look at the brain plasma ratio, ivosidenib, which was known not to get in very well, had a brain plasma ratio of 0.1, and vorasidenib, which was made to get into the brain, had a brain plasma ratio of 1.69. So vorasidenib got in much better. But you also note that you can give a lot more ivosidenib. Then they looked at the 2-HG levels in these tumors, and it's a log scale. So in untreated IDH mutated tumors, there's high 2-HG levels, and following treatment with vorasidenib, there's more than 90% reduction in the 2-HG levels. Ivosidenib in green also reduced the levels by more than 90%, although not as tightly as with vorasidenib. Another thing with these surgical studies is you can look at other biologic effects. And a previous study in Nature Medicine from Luca Bunzi from Heidelberg had shown that if you knock at the high 2-HG levels in these IDH mutated tumors is immunosuppressive. And so in this study, the reduction of 2-HG was associated with increased interferon alpha and gamma response pathways, and also increased infiltration of CD3 and CD8 cells, suggesting that inhibition of IDH and lowering of 2-HG can potentially augment the immune response to these tumors. So these studies led to the Indigo trial. This was a double-blind randomized trial in IDH mutated subjects above the age of 12 with grade 2 gliomas. They had to have only prior surgery 1 to 5 years previously, and they were required to have measurable disease, and they were felt not to be in immediate need of radiotherapy or chemotherapy. Patients were randomized to vorasidenib 40 milligrams daily or placebo, and the primary endpoint was time to tumor progression by blind independent radiology review. And a key secondary endpoint was time to next tumor intervention. So this study had 2 interim analyses before the final analysis. And in March of 2023, at the second interim analysis, the study was stopped for efficacy, and those patients on the placebo group were allowed to cross over to receive vorasidenib. When you look at the patient characteristics, it's balanced between the two groups, but one important point is that 80% of these patients had more than 2 centimeters of tumor. And so by the old high-risk, low-risk criteria, 80% were high-risk patients. This is the progression-free survival, which was significantly longer in the vorasidenib group with a hazard ratio of 0.39. And this is time to next tumor intervention with a hazard ratio of 0.26. This vorasidenib was effective in all the subgroups, and including both oligodendrogliomas and astrocytomas. And on tomorrow, I think, there's going to be, is it tomorrow or Saturday? Tim Clausey is going to present the updated results, because when the trial was stopped, the data lock was 6 months previously. So we had 6 months of additional data and follow-up. So that will be presented on Saturday. And the results confirm the original findings and in fact are slightly improved. So please go to that. And there's also a follow-up of the surgical study as well. One of the things that was done in this study, which again, we should do more often in our field, is that the pre-treatment scans were obtained in a subset of patients. And so on the right, you see patients' tumors are growing, and then they receive placebo, and it continues to grow. But here, on the vorasidenib arm, the tumors are growing, and then on treatment, there's some shrinkage of tumor. And so this is another way of looking at the effect of the drug. One of the really important things about vorasidenib, and as you have experience with this drug, you will come to appreciate, is that it has very few side effects for the patient. I've worked with many targeted drugs, and most targeted drugs are pretty toxic. But vorasidenib, in terms of the day-to-day symptoms, most patients will tell you they don't feel like they're on treatment. And so the quality of life is no different from placebo. It's not that the drug has no side effects. About 10% have hepatotoxicity, and so it requires monitoring. The recommendation is every 2 weeks for the first month, and then monthly initially, and then you can space it out later. So there are guidelines on what to do if you develop hepatotoxicity. With grade 2 and 3 elevation of liver function tests, you would hold the drug, and then when the levels return to grade 1, if it's grade 2, you could potentially resume at the same dose if it recovers quickly. But if it takes a long time to recover, you would reduce the dose. And for grade 3, you would reduce the dose. But these are guidelines that are in the insert. So as all of you know, in August, the FDA approved vorasidenib for the treatment of low-grade IDH-mutated gliomas. Before we move on, take a moment to answer the 2 follow-up polling questions about IDH inhibitors and the recent clinical trial evidence. I'll just give you a couple of seconds. So now that it's approved, I think one of the things we're trying to understand is who should be using vorasidenib. Should it only be those that fit the Indigo eligibility criteria? You probably are all aware that the FDA approval is actually broader than the Indigo criteria. The Indigo accrued patients 1 to 5 years from surgery. The FDA allows the drug to be started immediately after surgery. And for other cancers, you wouldn't be waiting for the tumor to potentially grow a bit before you start treatment. So treating early can be appropriate in certain patient populations. In the Indigo trial, patients had to have measurable disease. This was partly to allow responses determination and also to look at the tumor growth rates. But the FDA approved it for gross total resection. And again, it's not that the drug would work better if you have measurable disease. In fact, it should work better when you have no visible disease. And then in the phase 1 studies in recurrent tumors, the patients with enhancing tumors did worse. And that's because those tumors are probably higher grade with other pathways upregulated. But the importance of enhancement in newly diagnosed IDH mutated gliomas, I think, is somewhat different. So a significant subset of grade 2 IDH mutated astrocytomas and oligodendrogliomas actually have some enhancement, but they're still grade 2. And so there's no mention of enhancement in the FDA label. And I think if they have some enhancement, I think it's okay to use the drug. And then I think the real controversy is whether to use it just for grade 2 or for grade 3. In the past, grade 3 tumors did much worse than grade 2. But this is because it included a lot of IDH wild-type tumors. If you look at just IDH mutated grade 3 tumors, the difference in survival is much less than most people think. There was an MD Anderson study that showed no difference in survival. And in other studies, grade 3 patients did slightly worse than grade 2, but only slightly. And then the other issue is that the grading is not so distinct. It's a continuum. And pathologists will tell you that sometimes, you can call something grade 2 or you can call something grade 3. And so in some selected patients, maybe grade 3 patients could be considered. So this is just a case for discussion. This is a 37-year-old patient with residual grade 2 glioma. There's no molecular testing at baseline, but after testing, it turned out to be a grade 2 astrocytoma. And so the question is, what would you do for this patient? I mean, in some ways, this is the classical indigo patient. There is some residual disease, and one option would be to consider vorasidenib. The hope is that if you give vorasidenib, you could potentially delay radiotherapy and chemotherapy for some period of time. There are some patients, though, that you would not use vorasidenib. So for instance, if this patient was seizing all the time despite being on a lot of medications or getting progressive neurologic symptoms, those patients probably should get radiation and chemotherapy. Mamit, do you have any?
No, so I completely concur. I think one of the critical things that all of us do who work at brain tumor centers of excellence is that we have multidisciplinary team, right? So we have radiation oncologists there as well. But I completely concur with Patrick, but what I would also want to highlight some of the data that he showed, which I think was very remarkable, is that traditionally in brain tumors, I'm a medical oncologist, right? So we have tend to follow what goes on in the rest of the cancers, and we go for response rates, right? And now we are looking at this ways of getting MRIs to see what's the volumetric growth of the tumor. And as you saw mechanistically, that the patients who were on vorasidenib actually had a decrease compared to a 12% increase before they went on the drug. And those patients who did not get the drug continued to have an increase. So I think you can certainly try it in patients where you think you can delay radiation safely. And having a discussion in a multidisciplinary team, I think is always what patients like. And definitely there is a cadre of patients where you can treat with vorasidenib, as in the case in this with relatively low disease burden and hopefully not any great symptoms that need to be controlled.
So we'll finish with the last vignette from Linton.
I want to touch on that piece of that day-to-day life that you mentioned. You took that responsibility to adhere to this despite that impact, but I want to hear a little bit more about what that impact might have been like for you. I know you mentioned your wife noticed that it was changing your day-to-day or messing with what that day-to-day looked like. Can you talk a little bit about some of those changes that you noticed? Were you working at the time? Were you not able to continue to work? What were some of the changes that you were noticing as you were on this study?
So after both my surgeries, I'd run run out of energy at the end of the day, and if I had to go to some kind of a function or party, whatever it might be, I would always go either with my family or we'd go with two several vehicles so I could leave early. Very important strategy for me, because what would happen is I'd be tired at the end of the day. So those kinds of things, and then the importance of taking a nap. If I learned very early on that if I was going to take my medication at noon, that was my time, so to speak, I needed to change the channel, which could be taking a nap, taking a walk, talking to one of my friends, whatever. Also, what really became important to me, especially in the last 2 years, was reaching out to my 3 best friends. You know, best friend, best man at the weddings, and we were very, very close for well over 40 years each. And they want to know how I'm doing. I have changed my regimen, and not because I was forced to do it, because I adapted and adjust as I saw it. And I think everyone is unique. Everyone's going to have a different way of looking at this. That's why I think that it's really important, and not necessarily the drug company's responsibility, but certainly the oncologist's responsibility, to explain the range of potential side effects and how a person may change his or her life. But that part of the equation, that part of the whatever, can only really come from the lived experience, as you just said. And that's really important to be able to talk to people about. And this is why ABTA is absolutely critical, to get the word out, that there are ways to manage these things, obviously, and also to come to terms for those people who feel that that's the kind of way what they need to embark on using an IDH inhibitor, such as we have been able to use. And then finally, sometimes just talk to the neuro-oncologist.
So these tumors occur in young patients with good prognosis, and they have a number of issues that affect the quality of life. And so I think the vorasidenib is now a new option. And I think we have to discuss with the patient, with our colleagues in radiation oncology and surgery, about what is the best for each individual patient. But it offers a new option going forwards, in addition to all the previous ones.
So thank you so much, Patrick, for a very eloquent and comprehensive overview of vorasidenib and the data. Now we will spend the next 10 minutes or so looking at what else is there in Horizon. So obviously, Patrick had talked about grade 3 tumors, what to do about them. Obviously, the approval's more in grade 2. So we do know that grade 3 tumors tend to be more aggressive. So there is a study looking at through the alliance mechanism where radiation adjuvant temozolomide, which is obviously pretty much the standard of care, what we treat our patients with, vorasidenib is then being added. And essentially, there is stratification of less than 40 and more than 40, which obviously we know is almost a criteria of stratification factors in various trials, and then whether people have residual disease or not. And essentially, people will get temozolomide for 12 months, which a lot of the neuro-oncologists tend to do in clinical practice. And then those patients who are on the vorasidenib arm, which is the experimental arm, will actually get vorasidenib along with temozolomide, and then will get that until disease progression or unacceptable toxicity. And the ones on the control arm are going to get temozolomide for 12 months and then placebo. There are a number of other areas of interest which are being looked at, either through other cooperative group mechanisms, through the ERTC, company-sponsored studies, a number of other combinations with other chemotherapy agents, demethylating agents. Patrick talked about the immunosuppressive nature with the alpha alterations and role for immune checkpoint inhibitors. There is also interest in looking at this with other targeted agents, whether it's CDK4/6 inhibitors, amongst others. So this is a busy slide from a recent review by Dr. Ruda and colleagues through the Nature reviews in neurology, which outlines a number of drugs. We talked about vorasidenib extensively, which is both a IDH1 and 2 inhibitor with the high brain penetration, and you saw some of the data in terms of efficacy. There is also ivosidenib that has been used off-label. Obviously, we talked about it being approved for patients with leukemias and cholangiocarcinomas, and it targets IDH1. Again, efficacy in non-enhancing tumors. There are a number of other molecules. I'll talk about utilisinib later on, DS1001. These again IDH1 inhibitors with high blood-brain barrier penetration, which have shown degrees of efficacy. And then there are a couple of other inhibitors which are dual IDH1 and 2 inhibitors with high brain penetration, similarly like vorasidenib. Oltasidenib is an IDH1 inhibitor which has a high blood-brain barrier penetration. This was a phase 1/2 study led by Dr. Macarena de Fuentes, published in Neuro-Oncology. And here you can clearly see the waterfall curves. So on the first one, if you look at the RANO criteria, you can see 2 of the 25 patients actually had partial responses, as shown in the downward-facing green graphs. That basically means the tumors are shrinking. Upward graphs represent tumors growing. And as Patrick had talked about, a lot of these tumors actually just will have stable disease, and it's difficult to quantify what's the role of the drug in those when they get on a drug versus otherwise. And I think a nice way is to, if you can have volumetric assessment of what was the natural history of these tumors. This is an example, again, slide courtesy of Dr. De Fuentes, showcasing that this patient who had been on the drug for a fair amount of time, and you can see got a very nice partial response after 20 cycles. The DS1001 is another brain-penetrant IDH1 inhibitor, and this was a phase 1 study, again published in Neuro-Oncology in 2023, 47 patients, and you can see that 2 patients actually had complete responses, 4 patients had partial responses out of 35 patients who had some element of enhancing disease. And as Patrick had talked about, a lot of times, we will have a mixed component of non-enhancing and enhancing. Even around 20% of our patients with grade 2 tumors will have some enhancing component. And 7 patients who on treatment had brain tumor samples showed lower levels of 2-hydroxyglutarate. So mechanistically, you are showcasing that you are actually decreasing the oncometabolite. There is real-world evidence of these 30 patients reported by Katie Peters in neuro-oncology practice, which using off-label ivosidenib. And as Patrick had showcased, although this drug does not have as high blood-brain barrier penetration compared to vorasidenib, there is definitely responses. And you can see here, out of the 30 patients who were treated, 12 patients had stable disease, 5 patients had minor responses, 3 patients did have partial response, and 2 patients had progressive disease. And there was also clinical benefit. As I had told you before, often patients with IDH alterations do have a higher seizure frequency, and there was a stable or improved frequency seen in 70% of the patients. This is another experience with ivosidenib again. This time they measured the volumetric growth patterns in IDH mutant, both astro and oligodendroglial tumors. And you can see in 12 patients with grade 2 or 3 alterations, 50% of the patients did have more than 20% tumor volume growth. And you can see the patients being labeled from patient 1 to patient 12. And you can see in half the patients, there was a decrease as seen in the bar graphs going down. And ivosidenib was well tolerated and achieved a volumetric response rate in these patients. There is also vaccine-based approaches against the IDH, and Michael Platten and his group in Heidelberg has actually been leading this, and this is one of the study designs where they are looking at combining it with radiation and temozolomide. They've also looked at combining the vaccine along with checkpoint inhibitor in another study, as reported in a Nature publication. Patrick alluded about the Nature paper by Vince and colleagues, basically showcasing that excess 2-hydroxyglutarate actually is immunosuppressive, and as a result, it leads to a combinatorial study. If you can decrease the 2-HG secretion, as was shown mechanistically in other trials, you can use a combination of vorasidenib along an immune checkpoint blockade, and this is a study that Patrick and his colleagues are leading, where they are using a combination of vorasidenib and pembrolizumab and looking at what's the highest dose of vorasidenib that you can give along with pembro. The dose of pembro that is being used is the classic 200 milligrams IV every 3 weeks. Vorasidenib starting dose is 40, and you can dose de-escalate if that is too toxic to 20. And the maximum possible tolerated dose then would go into a randomized trial, which is a randomization of 1:1:1. The 3 arms, the drug is given preoperatively for 4 weeks, essentially. Vorasidenib given daily along with pembrolizumab in arm 1. Vorasidenib maximum tolerated dose is 40. We know from the Indigo study with only 10% grade 3 hepatic dysfunction, and untreated controls 20, and these patients will go to surgery, and then all the patients will receive vorasidenib and pembro. There is an upcoming SNOW presentation, so please make sure that if you are here tomorrow in the poster section, please check out this poster, phase 1 safety lead-in study, and then the randomized open-label perioperative study of vorasidenib along with pembro. This is a fairly extensive review. Again, Patrick was involved in this along with Dr. Miller, and a very busy slide, so I will not be tough on your eyes, but you will be able to download these slides. And this talks about a lot of excitement about looking at new inhibitors, whether it's vorasidenib, DS1001, we talked about that, glutaminase inhibitors, CDK4/6 inhibitors, and a number of other PARP inhibitions as well, because we do know work from Ranjit Bindra in his lab that IDH alterations can lead to a BRCA kind of alteration, and then you can use PARP inhibitors to really target that. And so there are a couple of trials looking at niraparib or combinations of olaparib along with immune checkpoint blockade to look at can you control these tumors. Again, a number of other ongoing trials which are going on, so it's really exciting as a physician investigator to see a slew of trials looking at different targeted approaches or combinatorial approaches with vaccines, immune checkpoint blockade, looking at these patients, and this is a very nice review from Dr. Ruda and her colleagues. So what else is going on? There is other publications and presentations here on IDH mutant glioma. So on the General Assembly on Saturday, you can actually look at the presentations from Dr. Ingo Mellinghoff, which is going to give you further updates on the phase 1 randomized preoperative study of vorasidenib and ivosidenib. Dr. Wen had talked about some of the initial results from this trial. You'll get more updated results which confirm the nice efficacy that was seen with 46% response rates with vorasidenib as well as 27% response rates with ivosidenib. And there is also then real-world evidence of frequency of post-surgical initial observations in patients with IDH mutations, looking at what is going on when these patients are given these drugs. So just to finish and recap, this is a 22-year-old female now who has an IDH tumor-mutated grade 2 astrocytoma, has had 1 prior surgery, and now is requiring systemic therapy to manage disease. Baseline testing confirms adequate hepatic and renal function. Patrick, if this patient comes to see you, what are some of the discussions that you'll have with this patient?
Yeah, so I think it depends on the extent of resection and the patient's goals for life. You know, if the patient has had a gross total resection and is an oligo, and the patient wants to have a child, you know, maybe just watching might be the first step that's reasonable. But this is also a situation where an IDH inhibitor would be reasonable. In a young person like that, you radiate them now. Radiation doesn't cause problems in the first 5 or 10 years. It's after that period that they start to have problems. And so if we can push that off, it would be potentially a good thing.
Thank you. And please answer these questions on your device before we open it up.
There are a lot of questions.
I know.
So,
Just signifies the interest.
so
So just before we start the questions, just some of the summary and take-home points. Obviously, you saw data on IDH inhibitors, particularly vorasidenib, demonstrating efficacy, benefit leading to the FDA approval for IDH mutant gliomas. There is a lot of emerging data from other clinical trials which will define future directions of combinatorial approaches as we went over, or the sequencing strategies. We did see that these tumors induce a fair amount of disease burden on patients, and very nice case by Linton and the ABTA. And we need to take that into account, because at the end of the day, we are treating a patient and also treating their families as they go through this process. Obviously, there was a lot of incentive, 3 Amazon cards for the best question. The first question actually is someone I'll ask Patrick, I don't know if you know, that does broccoli decrease the effectiveness of vorasidenib?
it came up yesterday at a meeting. So apparently broccoli does something to our hepatic enzymes, and there is some interaction. But the folks at Servier say, don't worry about it. This is not an excuse for you not to eat your broccoli.
So there's another question. In countries where vorasidenib is not yet approved, is there a vorasidenib program to provide compassionate use to patients who meet the criteria of published literature? I do know we do have some representatives of Servier Pharmaceuticals here, so I will encourage you to actually address this question with them. They're at the back of the room at the end of the program. Then the next question is, do you have an anecdote about a patient who went through successful IDH inhibition therapy? What did the patient value most about their treatment?
So my longest patient on vorasidenib was treated in 2016 and is still on drug. And she doesn't have side effects that she's aware of, but she comes from Wisconsin, so the main side effect is dealing with the airplanes coming to Boston periodically. That's her main downside.
I again want to highlight that point, as Patrick showed, that 10% of the patients really had hepatic dysfunction of grade 3. And a medical oncologist who's treated a patient with a lot of targeted therapies, a lot of our other targeted therapies have a lot of side effects. And as the patient discussed his case with everolimus, so those who have given everolimus, that is a tough drug. Or people who had given sunitinib on trials, or as I've given to my kidney cancer patients, those are tough drugs. From that perspective, vorasidenib is quite an easily tolerated drug where you can do weekly tests for CMPs, and then you can monitor them monthly. Also, a question that has come up, Patrick, is in Indigo, the PFS in the control arm is unusually short when corrected for predominance of high-risk, low-grade population. Is this because of the more detailed central RANO low-grade review process, or is there a biological explanation? What do you think?
I think these are high-risk patients. Also, not all the patients were stable. Recurrent patients were allowed on the study. And the curves are maturing, so I think on Saturday you'll see the results, and they're slightly different, but they confirm the initial benefit and extends it.
There's another question. If a patient asks, when I start this medication, will I have to take it forever? How do I respond?
It'd be great if they had to take it forever. I think this is a medicine that slows things down for a number of years. But eventually, I think everybody will need radiation and chemo. But you will buy them a number of years of life without the cognitive issues.
So I agree. I mean, I think, having been trained myself when I was beginning training, we had chronic myeloid leukemia, where patients actually had survivals of 2.5 years, and they had to get an allogeneic bone marrow transplant. And then we saw a number of drugs being developed and approved, and several of these patients are on these targeted therapies for decades now. And some of those therapies are much tougher, I've given them, compared to vorasidenib. So I completely concur, and as Patrick shared, his patient has been on the drug for 8 years. And eventually we do know that there will be other resistance mechanisms which will develop in a fair number of our patients. But if the patients can't tolerate it, we tend to give targeted therapies as long as patients will take it. And if patients are having side effects, we always give them a disease holiday. It tends to happen a lot with sunitinib, because it's very difficult for patients to take, for example, sunitinib, as it's given for kidney cancer on an ongoing basis. So a lot of times you can actually induce a drug holiday for letting people to recover. Next question, Patrick, is synergistic effects when combined with other therapies. I know you and your group are doing a lot of work, especially with the trial that you're leading with Pembro. What are your thoughts?
Yeah, so for the immunologic effect, there's the vorasidenib pembrolizumab trial. There are vaccine trials that Duke and I think Heidelberg are doing with vorasidenib. We're doing radiation and temozolomide with vorasidenib. So there are some studies looking at combinations. Hopefully, as we understand the mechanisms of resistance better, then there'll be more rational approaches for combinations going forwards.
This next question is interesting. In some patients with non-enhancing low-grade glioma that I started the targeted medication, the first MRI after the medication for 2-3 months shows faint enhancement. As theoretically the inhibition of IDH would increase the immune response, should I interpret the faint enhancement after starting IDH targeted therapy as an immune response or not? So what to do? Stop therapy, worry about progression?
I would worry. I'd watch them to make sure that it continues to worsen, but it's probably progression and not an immune effect.
I think as we do use these inhibitors more and more, we will also get more real-world evidence, and probably in the next few years we'll know a better idea. But as Patrick said, sometimes we will do a short interval scan, keep them on it, but a lot of times as we have treated brain tumor patients, we know the follow-up MRIs do tell us the natural history of this disease. Would you use vorasidenib for patients with IDH mutant grade 4 astrocytoma? Can the Indigo results be extrapolated to patients with grade 4?
No, but the company is launching a trial adding vorasidenib to adjuvant temozolomide in grade 4 patients. And so I think it's worth exploring, but the Indigo results you can't extrapolate. You need to give these patients radiation and chemotherapy as well.
This is a question as a follow-up. With increased risk of epilepsy and thrombosis with IDH mutant tumors, do you use anti-seizure medications and or aspirin prophylactically in these patients?
So I think it's actually the reverse. IDH wild-type patients have a much higher risk of venous thromboembolism. IDH mutated tumors have a lower risk of venous thromboembolism. But IDH mutated tumors have a high incidence of seizures. And there's some suggestion that the 2-HG contributes to the seizure. So theoretically, an IDH inhibitor should lower the seizure frequency. In the Indigo trial, in the initial paper, there was no real difference because patients with refractory seizures were excluded from the Indigo trial. But I think in Tim Clause's talk on Saturday, he will allude to some of the differences in seizure outcome when you're on vorasidenib.
Next question is, can liquid biopsy or FET-PET CAT scans be used to determine the grade of recurrence to help decide if vorasidenib might work?
I think that's the goal, to have these things. I think right now liquid biopsy is not sensitive enough, but people are working on it. And PET scans in a subset of grade 2 gliomas are not positive. So I don't know how sensitive it is.
I think then there was another broccoli question, but we already answered that. How soon can we start to consider the repurposed drugs that have come up?
I'm not sure I understand. What?
So how soon can we start to consider repurposed drugs that have come up? What I can just say is that, over decades, there has been a lot of interest in repurposed drugs, right? We've done trials with metformin and a number of other drugs. And so far, what I would say is we have not had the kind of success that we would have liked to. But I think overall, as you saw, with the high degree of activity that is happening in terms of number of ongoing trials, The vorasidenib story is a beautiful mechanistic story of how we identified an IDH alteration in 2008, how the trials were done to mechanistically answer the question whether we give the drug, do we show a mechanistic decrease in the tumor growth, and then obviously the clinical results has really ushered, which I hope is going to be a new era of drug development in brain tumors per se. And I think this is a big plus. In interest of time, actually, we will encourage you to ask your remaining questions. Patrick and I'll be available. But what I want to do say is congratulations to the 3 Amazon gift card winners. If you're in the audience, Peter Kins, Yi Hao, and Erica Hotta. Thank you so much for submitting your question. You are the 3 winners today. Please see Melinda on the left of stage. She's waving a hand to come and please claim your card. And I would really like to thank all of you for being a very nice audience. And Patrick and I'll be available for next 15, 20 minutes to answer any questions that you have. Thank you so much and have a great evening. And good luck with the rest of the snow meeting. Thank you, Patrick.